Or do I just go, I can go to my presentation. So
Yeah,
when I click this, you guys see everything?
yep.
All right. So I guess for all those of you that are joining in, Assalamu alaikum. My name is Noman Siddiqui. And thankfully, the MPN has given me the opportunity to present to you a short little presentation on fellowship, especially focused around my fellowship, which is the Foot and Ankle Deformity Correction and Orthoplastics Fellowship. It's a mouthful, but it's a fellowship that's been around for actually a long time, and and I'm going to talk about a little bit about myself. For most of you that probably don't know, I'm a podiatrist here in Baltimore, Maryland, where the fellowship is based. But prior to that, I'm from the Midwest. I'm from Indiana, and I graduated Indiana University. For those of you that are Big Ten folks, subsequent to that, I went to podiatry school at Shoal, and then ultimately did my residency in Scranton. And after my residency, I did my fellowship where I practice now. It's known as the Rubin Institute for Advanced Orthopedics, the International Center for Limb Lengthening, and I did a one-year fellowship here in 2012, well, 2011, 2012, and I've been here ever since. Currently, I am the Director of Podiatric Surgery and the Division Chair of Podiatry at Sinai Northwest Hospitals, and obviously the Fellowship Director. I'm also affiliated with the local residency program. It's the Baltimore VA Sinai Hospital Residency Program, and one of the core faculty, as well as I believe I'm also an assistant residency director. But the director is Dr. Abawi, and I help out where I can. For those of you that may or may not be familiar, here's just a brief oversight, and always people are interested in, number one, where the fellowship is. It's in Baltimore, Maryland. It's it's in the Mid-Atlantic, a very popular area between Virginia, DC, Maryland. And, you can see the salary there. It's not some of you are probably making more than this, but it's competitive with the PGY4s at our institution and the surrounding areas. If you decide to do a fellowship here and get here, I am centered in multiple locations. Home base is Sinai Hospital, and then we have sister hospitals, Northwest Hospital, and there's another hospital in the system called Carroll Hospital. But I don't generally go there. All these hospitals and locations are based out of LifeBridge Health, which is the health system that provides service to these individual centers. But for me, the main locations are Sinai, Northwest, a surgery center, and multiple outpatient office locations, multiple meaning 2 or 3 that I rotate between. So the setting, I'm a hospital-based podiatrist. So what that means is I'm in a multi-specialty orthopedic group, and I'm the podiatrist in the group. And now we also have a foot and ankle orthopedic surgeon. Some of you may or may not know him. His name is Dr. Christopher Bibbo. He's been with us since 2016, and he's also faculty currently at with the fellowship. And our focus is this. I mean, for me, it's pretty much musculoskeletal surgery of the foot and ankle and distal tibia. I do adult and pediatric surgery, for those of you that are interested in peds. I mean, I don't do completely peds, but I do a fair amount of pediatric operations. I do a lot of minimally invasive surgery. That's a thing that is associated with my practice, and something that I've been doing since 2012. External fixation, I chose this fellowship when I did it in 2012 because we did a fair amount of external fixation at that time at the center for various reasons. So I have a specialty in external fixation. I also consider myself an expert in deformity correction, especially when it's associated with the foot and ankle. I've been doing this a long time. My fellowship centered around it. More recently, I have become, due to our relationships with the local Division I school, Loyola, as well as multiple area high schools, I am the foot and ankle person for Loyola, as well as many of the high schools. We have a really robust relationship, so I get quite a bit over the past 2 or 3 years sports medicine on high level Division One athletes and high level high school athletics. So I'm kind of proud of that to add to the fellowship. And then with most fellowships, I would think that, and for me as well, limb preservation, limb salvage is very important. Now, it's very important to note we don't have a robust coinciding vascular surgery department. So I always say limb preservation and salvage is very designed on functional limb salvage and limb preservation. And I can get into more of that. But that's, in a nutshell, what I am. I also like to kind of simplify it. I call it, the A, B, C, D, E, F's of Siddiqui on things that I like to do to kind of make it easy. And what that means is, you know, arthroscopy, ankle replacements fall in A. So things in and around the ankle are important. B is for bunions, brachymetatarsia, and very biomechanics-based surgery. So if you're in my fellowships, most people or anybody who's been a fellow of mine would know I am very big on biomechanics, surgical biomechanics. C falls for cavus and Charcot. That's a decent part of my practice. D is for deformity. And that could be for a variety of reasons. And I'm one of probably the few people that does in the limb lengthening space. I do perform limb lengthening focused procedures, a distal limb, as well as the foot, not for cosmetic reasons, obviously. It's for the conditions mentioned in this slide. External fixation, we talked about that. The F is for fusions, and I do gentleman's trauma. We don't take trauma call, but I do get, periodically ankle fractures that are coming through the office. So it's gentleman's trauma. And that jumps to M. M is not only for Muslim, it's for minimally invasive for me. And that's my mindset. It's 90, my mindset is 100% minimally invasive. That doesn't mean everything is done through a poke hole, but the mindset is there. And until you're a fellow, it doesn't make sense. But here's an example of a case. Here's a neuropathic case that most people, when they look at it, if you're doing any neuropathic-based surgery or Charcot joint surgery, I'm traditionally trained, so this is open surgery. But my mindset, in my mind's eye, I see all these lines and prep, and how do I do all this stuff? And ultimately, because my mindset is 100% MIS, I'm able to do what needs to be done to correct what is a traditional orthopedic neuropathic fracture done through a minimally invasive approach. Now, what is obvious is the bony reconstruction, but what less obvious is the soft tissue reconstruction that's being done at the same time, and we can get into that. But ultimately done with the MIS mindset, correcting everything, restoring all the biomechanical parameters of the foot and ankle. So all the things that I'm kind of mentioning you, ultimately leading to fusion and proper healing. And you can see being very orthoplastic mindset about it, minimizing the soft tissue trauma to this area. And then you can see as that deformity stuff gets worse or more complex, the mindset doesn't change and the application is still the same of doing a minimally invasive approach, regardless the severity of the conditions that come in. And I'm just going to gloss over this. I'm trying to include a variety or a compilation of the types of cases a fellow may see or experience throughout his or her training. And you can see this is just all deformity correction, all osteotomies. There's the distal tibial osteotomy. There's the foot reconstruction. So someone with a really severe congenital deformity, which affects their hip and knee, can have complete restoration in an anatomical way with a minimally invasive mindset and approach to restore function so they can ambulate much better. And you can see that here, this patient is now actually functional, whereas before they weren't and had a hard time just even getting around. So the mindset is there, the complexity is there, but again, it's all built on the concepts that I learned from minimally invasive surgery, the bunion. And that's my favorite surgery I do. For those of you that are going to look at this, that's, if I could just do 50, 60 bunions a day, I'd probably give everything else up because I enjoy it. It's the only procedure that with near a 98 to 99% certainty, I can say is going to end up with a good outcome and be pretty consistent where I don't have to think about it. And here's now most of you, to you guys, this is like common things that are being done, minimally invasive surgery. It's not uniquely new anymore, which it used to be, very much so. So here you see everything. These are some cases of mine. I'm just trying to show you a variety of minimally invasive type of cases. This is obviously hallux valgus. Obviously, here's flat foot. It's part of the F. Done minimally invasive, doing calcaneal osteotomies, and more evenly if it gets really significant, like in this case, you have ankle arthritis, a tear joint arthritis. There's a bone spur of the first MTP, all done through MIS prep and MIS correction. And my partner, Dr. Chris Bibbo, he does a lot of this orthoplastic stuff. I do it as well, but I'm not microvascular trained like he is. He did a microvascular fellowship at Penn, so he's a very trained and high level person. So you will never see me saying that I'm an orthoplastic surgeon or reconstructive surgeon. Do I do these procedures? Absolutely. Do I know how to do these procedures? Thankfully, I do. But that is not something I advertise, because in the end, I don't have a fellowship in it. So I'm not a big fan of advertising things that I did not get formal fellowship for. So you are going to get exposed to this, but is it going to be the first line? Probably not. Way of doing it. But if you need to do it, we do it. And here are examples of limb preservation and limb salvage types of cases that can be done using very nice orthoplastic techniques. So in general, if you go to the website and you pull up the PDF, you'll see this on there. Kind of gives you a brief overview of the things that you're going to be seeing and doing. But it's relatively simple. For me, the expectations are very, very simple for the fellow. I call it back to basics, meaning I don't expect you to focus on the most complex things. I want you to look at it from the most basic standpoint and build from there. Additional responsibility to the fellow, I let them kind of teach and supervise the residents that are on the service. I call them the leader of the service, more so than me. I might be the head, but I need somebody who's the neck to make sure they're seeing everything, they know which direction I need to go, because there's a lot happening at the same time, and they need to be aware of the front, back, side, up, down of what's going on for me, because it can be at times be a busy service, but I keep the fellow busy for what will be functional, meaning I expect them to publish. That's the best currency. And I'll get into that. The best currency for any fellow is what they publish out of their fellowship. So it is very important when they come here, they're ready to submit a manuscript, and I can get them the topic that they are submitting. One of my most prolific fellows once submitted, I think, 10 or 12 of those and had like 11 accepted. So I'm not saying that everybody has to do that, but they can at least do 9. I'm just kidding, but at least a decent amount. You have to try. And many times when the fellow shows up, they're either continuing a project, finishing a project, or starting a project. And it's a combination of actually all three usually. The next step, in the fellowship, you have to work hard, but you have to have fun. You have to enjoy coming to work like I do. I enjoy going to work. I enjoy working. I enjoy the things I do. And this is important. You have to be a team player. There's no fun when you're just only thinking about yourself, because that never works out well for anybody. So my method of teaching, I do not expect you to be a reconstruction surgeon. That's important for you guys to remember. When you come to me, I don't expect you to know how to do everything. I don't even expect you to be a master of anything. Now, if you are good at certain things, like for example, until I recently adopted better arthroscopy skills, most, if not all, my fellows were better than me. So I learned a lot from them when they were doing arthroscopic cases. But I do expect you to know basics of everything. And this is, because you can read. You don't have to be, you don't know how to do, but you can read. Like biomechanics is a must. You can't show up to me as a weak biomechanics person, that because we're not then in the same field. Not because I'm going to be mean about it, but we need a baseline to start. Surgical principles, you have to understand some basic surgical principles. And then patient management, who to admit, triaging, what's urgent, what's emergent, what's necessary right this second, in the office, how to be efficient, all these things. So I expect people to do that, because if you can do that, the image is very important for you guys to look at. You can see it all builds upon what you know in the past. It doesn't mean you have to know everything. And if you look at the picture itself, I don't expect you to forget everything. If you like, for me, I like to golf, I like to teach, I like to build, I like to be out. I want all those aspects of you to be there so you can be a better surgeon. Because ultimately, all this makes sense only if you pay attention to each individual piece. So as you build your career, you have to pay attention to everything as you go about it. So in a nutshell, I'm sure it's not complete and comprehensive here, but my hope is that you are getting a sense of what the fellowship is like. So with that being said, I'm happy to take any questions.
If anybody has any questions, feel free to just jump in, and you can unmute yourself and just ask a question. I guess I can start out. Can you tell us a little bit about your adopting of MIS techniques? Like, how far into your training did that start for you?
Also, in my training, it never really was formal, meaning I was always interested in it from the beginning of everything. When I started fellowship, before that, I was a resident. I was interested in it, and I knew when I got out that this was something I was going to adopt right away. So when I came out into practice, I started doing it right away, and I did not have any formal training. What it did was it only taught me more about everything else, how the biology of things heal. And so, yeah, it was unlike now where it's a formal thing where people are seeing it, reading it, and being taught this, even at the industry level and at the national meeting levels. We didn't have that then because it was very, very much, this is 2012. This was not a long time ago, but now it feels like a long time. It was like you did not do this stuff. You just didn't do it this way. So alhamdulillah, I kind of stuck to it, and it worked out. And now it's a very more common thing, so people don't think I'm nuts.
Would you?
Assalamu alaikum, doctor.
No, go ahead.
Assalamu alaikum, doctor. My name is Mustafa. I'm starting residency this coming July, and I already tell myself that I'm interested in fellowship, but what are some things that I could be doing in residency to kind of just be ahead, and then to kind of make myself a great candidate for fellowship? Because what I often hear is that just because you didn't go to a strong residency program, etc., or your residency program wasn't focused on certain aspects, don't expect the fellowship to fulfill those deficiencies. How true is that? And because I'm personally in New York, and scope is a factor, unlike other states.
Sure. No, that's a good question, and there are some regional challenges. There's no question that is going to affect you if you're looking at going into a fellowship. Now, I'm not going to speak for other fellowships, but I'll tell you what our fellowship focus is. For me, the fellowship is they have you fill out a bunch of forms, grades, recommendations, all those things, all the things that a standard fellowship does. And number one, I don't look at your grades because I don't think you guys are already smart people. That's my baseline. You wouldn't have made it this far getting into residency and then completing a residency because if you weren't intelligent. And something that you did in podiatry school, I don't think necessarily translates to what you will be doing now. So that's number one. So if you have suspect grades, don't worry about that. The part that does matter, and to your point is important, is your residency experience. And what that means is, what did you do during that residency experience? How did you maximize it? If you have to, during your residency, decide what you want to do at some point. And that's sometimes hard, but you have to start thinking about, am I going to be a surgeon? Am I going to be a private practitioner? Am I going to be a balance of both? And it's hard to know that in the beginning, but you still have to actively think about it as you go through your training. And I'll just talk about me, I decided I wanted to be a surgeon a long time ago. Like first year of residency, I'm like, money was not the focus. Nothing was besides being able to do the kind of practice I have now, function at a high surgical level. And I did everything possible to do that. That meant read, be in the operating room constantly. And that was the mindset now. And for me, fellowship was the natural progression of that. I think nowadays, things are different, and I completely get that. So if you are focused on like, hey, I want to make a ton of money, great. Then you should focus on making a ton of money, because then you'll probably be good at it, right? Because I don't think being a surgeon, like a high level surgeon, is cohesive with being like financially savvy in the beginning. I don't think those are collinear. I think one begets the other, maybe. So that's why you have to be honest with yourself, and don't do what other people are doing just because that's what you think you should be doing. Meaning, I knew young people that were like, "Oh, I want to do this. I care about the stuff you do, Dr. Siddiqui." But many of them, they thought that's what they should say to me, because I would be happy or impressed, or they were impressing themselves, or they thought they did. And so I think you have to start off being honest with yourself. So for you as a first year, if you enjoy being in the operating room, be in the operating room all the time. It doesn't matter. That means I used to scrub into everything. My job was to see, do, and be in and around an operating room constantly. And that helped me. And it's helping me even to this day. So that's number one. So and then you can decide, like, okay, there are so many fellowships now. What is the focus of that fellowship? Some fellowships are going to prepare you better to be a practitioner in the office. Great. Some will make you a better biller. You just have to kind of go about it. And it's hard to know exactly which guy or gal you're going to be. But I do think that having that purpose is important. And now the other thing is, one doesn't make the other one. One isn't better than the other. And that's the most important thing, that what is important, like, for example, me wanting to focus on surgery doesn't mean that somebody else who wanted to focus on being a good community podiatrist, or being in a private practice, or a good biller, that is less. It's just different. I did everything to end up in the situation I'm in. And alhamdulillah, also, with God's grace, I ended up where I wanted to. So I think you have to see it, like, that's what I want to do. And you kind of focus all your efforts and energy around it. And then it works out generally if that's what you do. So for you, if you're like, okay, I'm in New York, don't look at what are the weak points, because that is, and there's no question New York has those, but that doesn't mean that you can't overcome those. You may not get exposed to a ton of ankle at New York. That's okay. Then go into practice. Go practice somewhere and get ankle, or go into a different program. I mean, again, these are financial decisions you have to make if you're weaker, because if you think that I didn't get enough, you have to, because that's what like the podiatric forefathers did. They didn't have some of the guys that are these famous folks around the country. Many of them didn't do any of this stuff. Look at me. I didn't do any MIS. I just started doing it. So I think you have to kind of make your own path sometimes, and not look at your immediate situation. Actually, a good example is my incoming fellow. His name is Ali Khazal, and he's in Detroit. Good guy. And he's interested in, he had been messaging me since he was a student. I'm like, okay. And here he is, he made it his singular focus to do the fellowship with me, and alhamdulillah, it worked out for him. And he makes his own experiences, and he's very laser focused on what he wants. And inshallah, that's why he's going to end up in a good situation and get what he wants. I think those folks that, are commit to it, and they don't listen to what other people are doing, they just kind of focus on what they want. They're the ones that do end up succeeding in what they want out of their pursuit. I know that's a long way of answering your question, but it's a very good question, and I didn't want to just give you a simple answer.
Barakallahu feek, jazakallahu khair. I generally believe that the advice you gave is nor generic or superficial. It was actually very profound, and I felt was very relatable in every aspect. It resonated very strongly with me because, not to make this about myself, but I feel like, I have a lot of ambition and drive, and I chose podiatry from early on from high school, and I had a passion for it from that point. Um, but subhanAllah, because of family and familial obligations, I decided that it's best that I stay in New York, and I was just kind of like the outside noise is like that kind of is like a cloud where like you're going to be limited. And subhanAllah, a lot of people, anytime that I tell them, oh, like I'm excited, inshallah, I want to do a fellowship, they're like, oh, don't expect the fellowship to fulfill these things. But like you said, if you hustle and if you work hard and if you read literature throughout residency and are proactive, and then you go on to do a fellowship, inshallah, and things will align. And to my understanding, it's like you're always going to be learning. You're always going to be trying. Because I see some attendings in the OR, right, like that are trying a new technique or a new system, and so there's always like courses, right, that one can take, whether it's like the scope course with ACFAS, etc. So those things kind of give me hope and more inspiration in terms of just like being a better, like, well-rounded person. Is that true?
Yeah, I think it's important you find mentors, like that you find, whatever that may be. And like, for example, if you're like, okay, if I keep on reading this stuff from this person, I keep on hearing about, or if I go to lectures and this person is doing this, then go to it. For example, somebody is great at private practice, right? And you're like, man, this person does well, and they do well professionally, they're doing well financially, they understand billing, they understand coding. Then you go spend time with that person. That's the way to do it. You just don't go, hey, can you tell me how to do it? No, you actually go spend time with that person. That's what people did back in the day. They actually, it's an investment in themselves. And I think I would do it. That's how I would do it. Like, there are friends of mine that are foot and ankle orthopedic surgeons that are very good at certain things, and I have been like, oh, I'm going to go do that. I'm going to go spend time with them, and every time I see them, we're chatting, we're in the lab, we're talking, and it's this active learning, and it's a different way of learning. Some of my close friends, they'll call me up to this day, and they're like, hey, how did you do that? Let's talk about it, and we'll go through it, and I think it's better for them. It's good for me. We're always learning together. So I think if you want to be good at something, you have to go find the guy, the gal, the group, or whoever it is, and get that information from them. But nobody's like, for example, none of us here that are teaching are sitting here as like some kind of, Salahuddin Knights who are just going to go, okay, now you're able to do it. You have to do the work. And then the rest you have to, sometimes also what your situation is. For example, you may be fellowship trained. Like one of my fellows, she trained with me, but then her life changed. She ended up, she changed her mind. She wanted a different type of practice. And that's okay. Made the conscientious choice, wanted to go in a different direction. And that's okay. So I think you're allowed to change your mind, because that's also important. Things happen. And I don't think that's a bad thing. It's just, at least when you're going about through the process, just don't be like, oh, I'm going to do this because I need to buy time. I don't feel good about it. I think the best fellowship is being in practice. More important than even being with someone like me or anybody else. You will learn more by actually doing and being in it and having the stress of it than you will just going to someone and going, okay, this is a buffer, I need this. I say just go practice. If you're uncertain about doing a fellowship, you're better off just working, and you'll learn a lot more. And then you'll be even more like, okay, I need this. I need this information. And I think those people actually might do better in the long run because they become more laser focused.
Dr. Siddiqui, I would like to open the floor up here if anyone else had any questions.
Yeah, assalamu alaikum. Just a quick question, kind of piggybacking off of what he asked, but how important do you think fellowships are in like today's culture and podiatry and stuff?
It just depends. I think it's become, for your all's generation, a baseline. But also it has some negativity surrounding that baseline because now there's so many. And so it becomes, okay, did you do a fellowship? Who did you, because now it becomes granular. Who's the fellowship director? Okay, what are you doing? What did you publish? Because that's your currency. Because I tell our fellows, I mean, there's some podiatrists that know who the heck I am, but most people don't know who the heck I am, and nor do they care. But when you publish, that's your currency. Nobody can take that away from you, and that's what you have. So I'm just like, that's most important. That if you're trying to be a known entity, that you create some value or currency behind yourself, and that's by publishing. So I think fellowship is important, but it depends. For example, Dr. Maksud, he's at University of Kentucky. I think in an academic institution, it only helps. If you're in an orthopedic environment, and I think it does help because that is something that they're familiar with. That doesn't mean it's the end all be all, because there are plenty of podiatrists that are not fellowship trained. So it can help you, but it doesn't, if you don't have one, doesn't mean you cannot overcome that. For example, if you're going to be, and I'm going to use Baltimore, if you're going to be in Baltimore and if you want to work at one of the major medical institutions, I think you're probably going to need to be fellowship trained, at a baseline, because it's a major metropolitan area. Now, if you're 50 miles outside in the community setting, I don't think it makes a difference. The fellowship will help you. You're never going to be harmed by knowing more information, but the patient population may not care, and nor will the referring doctors, because many of them have trained at good institutions and maybe fellowship trained themselves. But your work is going to matter more. Your decision making, your community savvy, your interpersonal relationships, your ability to have a good name. There's a person within a 15-mile radius of me, fellowship trained. I won't take their name. Fellowship trained. Unfortunately, had a couple cases that just didn't go right. And the people that they didn't go right on were practicing healthcare providers. Communication was bad afterwards, whatever it was. And now I have this steady stream from that area of patients consistently. That person's fellowship trained. But it's not that they didn't do a good job. They just didn't communicate well afterwards. And that created a damper. So I think being able to, and that's why I say you also have to be like able to interact and grow yourself. So if you're going to be in a situation where you're not fellowship trained, you have to overcome it with other factors. I don't think that's going to be the most important thing. There are plenty, Chicago is a great example. There's so many podiatrists in Chicago, non-fellowship trained, that are doing really well. So does it help? I'm sure if they're fellowship trained, sure. But if they're not, So I think you have to look at the situation you're trying to go into and where you're going to be.
Like I appreciate that. Thank you.
Mm-hmm.
What are the questions we have out there?
Well, I think what you guys should, while you guys are thinking about it, I'll tell you other things that you should be aware of. And we can, I think it is very important in today's day and age. Oh, we have a question here. Dr. Junaid Khan.
Hey, assalamu alaikum. Sorry, I'm
Walaikum
just
assalam.
out here
it's
chasing my
okay.
kids around.
Good.
Jazakallah khairan for taking the time to do this. This is great. I wanted to ask, I know you mentioned that your current fellow has been messaging you since he was a student, and I've heard before that you'll take people kind of in their first year of like their PGY1. You kind of have commitments from residents early on. So what advice would you have to someone that wants your fellowship specifically?
Yeah, so that was unique. He was the only one that I've taken as a PGY1. My general people I take are PGY2s, primarily because I want to give them direction into what, like in the other, for example, in orthopedics, you don't get into your final year and then apply for fellowship. So for me, it's important that I take somebody who has now a vision. Like for him, I was like, okay, here you're coming like this. I need you to become savvy in this. For example, my last fellow, Shane Sato, he trained at Cambridge Health Alliance, very good program, very good resident. And when we picked him, he was like, I'm nervous. I don't know if I can do the research. I'm like, well, then your job over the next year is to learn how to do research. And sure, this past year, he submitted multiple manuscripts. He's submitting multiple papers, and he even won an award at ACFAS for his manuscript that he submitted. So if I'm going from not having the experience, kind of being apprehensive about that experience, to getting an award at our surgical society meeting is tremendous, So it is designed for that, so you can overcome these, concerns or your blind spot, so to speak, that you're like nervous about, and you have to be able to accept that you have a blind spot to grow from it. And I'm very proud of him that he was able to do that. So that's what I would say. If somebody's looking, I generally take second years. If you're looking to apply, you should apply in your second year and be willing to come by and hang out, because equally as much as you want, I'm getting to select, I expect the people that are coming to want to be with me, because they can talk to, I don't try to hide anything as far as what they're going to be, the kind of experience they're going to get. So, yeah.
Thank you, Jazakallah.
Mm-hmm.
You were about to say one of the most important things we had to keep in mind, and then we went to the question.
That's the problem with being an uncle who gets like strokes and I can't remember anything. There are a lot of important things, but I think the most important thing with fellowships, and I'll tell you, is I think you guys are in a competitive environment. So there are two parts of me that always say, the best fellowship is practice. But you guys, that being said, you guys are in a competitive environment where your competition, and this is hard for you guys to maybe understand at this stage. Your competition at a baseline is your fellow podiatrist, but that's not who you're competing with. Your competition is orthopedics, and orthopedics is going to beat you unless you try, unless you fight back. And that doesn't mean like physically or intellectually. No. Meaning with effort, because they're going to actively be stronger than you if you let them be, because they have the privilege of bias on their side. People are automatically going to assume that they know more, can do more, and be better. And that should not be taken as something that you're like, oh my God, this is so unfair. No, it's just the reality of the world. And I think, so to that question that was earlier, like, hey, how does a fellowship make me look better? Yes, perhaps. But what makes you look better is you. How well read you are, how up to date you are on everything, how you're easy. Like I said, the totality of you makes you the better person in a competitive environment like this, because they're not trying to do you any favors. No one is. And that's why it's important. Like in private practice, same thing. You're going to be competing with multiple podiatrists, multiple practitioners, multiple orthopedic groups, in the wound care space, in the limb salvage space. It's getting competitive. So I think you guys have to remember that you have to make yourself strong at every level. If you want to be good at everything. So I always present my hospital-based slant, because I'm a hospital-based podiatrist, so I don't know what the private practice world is like. So if that's a different animal. But there are going to be similarities that you need to be willing to adapt. You need to be willing to work. And there's no such thing as fair, because there's, and you guys know that in general. And I think as soon as you get past that, you can succeed. Is like if you expect things to be fair all the time.
How have so I mean, you're probably one of the more prolific, if not the most prolific, like Muslim podiatrist that's at least in the public space. Can you tell me a little bit about that experience, being a minority, so to speak, and how
That's a good question. No, that's really nice of you to say, but Alhamdulillah, Allah has been good to me, in beyond measure in any way I can ever, be thankful for. And so I say, you have to. That's number one. That's who we are. If anything, being a Muslim is central to how you function, and I think medicine is perfect for that, because it allows you that you're not going to try to cheat anyone, right? I mean, those are just general. Most people think these Islamic principles. You're not going to try. You're going to be caring of the people in front of you, irrespective of who they are and what they're doing, because those two, especially in today's world where there's all this surrounding stress of what's going on, it's really hard because you have to take care of everything and everyone impartially. And I know it can be a challenge, but that's where, sabr and all the things that the religion teaches you becomes important, and that your goal is to follow these ideals. And we're not perfect. I wish I was better in every aspect of it. So I appreciate you saying that. But I do think depending on where you are, you have to keep that central, because most people that you might be the only person they interact with. Because I do a lot of industry related involvement too. Some of those folks are the first time they're ever meeting a Muslim, right? So you kind of you can be a very influential representative for them, and how they view everybody. Actually, a few years ago at ACFAS, I think maybe like 2 or 3 years, maybe 3 4 years ago now. It was just around the pandemic, before the pandemic. One of the company reps came up to me, and he's like, "Man, there's a lot of people that look like you here." I'm like, "What?" He's like, "I don't know." He's like, "There's a lot of people with a beard that are South Asian." And I'm like, "Yeah, that's true." So, like the dynamics are changing and they're noticing. And it's true. So I'm happy to see that, there's a lot of Muslim kids, a lot of South Asian kids, a lot of um, young people that are representing, in a positive way, what it means to be a Muslim in podiatry. So, and you guys are doing that. Like I was blown away. I loved the Jummah that was done at ACFest this year. It was probably one of my favorite things. I had to call my wife up and tell her that I did that. I really enjoyed that. So I think that's what you need to do. Maintain our identity, and be your own narrative. Don't let somebody make the narrative for you. And that's what I've done. Is I try to be the guy that people see, but I don't shy away from the other stuff, like expressing my views within context, because it's important that you guys remember that the world is, like I said, it's not fair. So you have to be mindful of that. Be mindful of what the world that we're living in, and make decisions that are that you can be comfortable with. So I think that's as I guess the Muslim represent, and I don't try to be that for you guys, because that's the other thing. I don't want everybody to assume, that I don't lead with that. There are a lot of other Muslim folks out there that you wouldn't know that are Muslim, because they know that, and I know that too, that I can't make the way the world works. They kind of lump everybody together, and so I'm mindful of that. So, but no, you guys are all doing a great job at representing not only Muslims, and I think you guys are doing a fantastic job, perhaps even a way better job than I could ever do. I'm just doing one segment of it, which is making sure that we publish some articles.
Well, that's the real meat of things. So I guess without the ability or the knowledge, a lot of it is fruitless. So we definitely appreciate your work.
Well, one of the things I will tell you is that you guys shouldn't, and I tell this, that representation is important, but I think it should not be the focus. Because there are a lot of people that, because I'm in these circles of folks, and regardless of what their opinion is, personal opinion, if you are good at something, you will be seen. Period. And I think that's very important for the young guys, the young gals that are coming up, to remember that. Because the error that can be made, and I'm not saying that it's not important, the error that can be made is like, I am not getting something because I am this. Because I've heard it from a few of my fellows who've been, blonde females. They're like, oh, I'm a female, and I'm like, that's not the reason you're not getting something. To be clear, because you're only going to get something is if you're relatable, you have values, you do the work. That's it. And once you get in, like, for example, and I'm telling you guys this, why do people pick certain people to be on a circuit? Like, oh, hey, I know he's a good guy. Oh, you know what? She gives a great presentation. That's literally the conversations. Now what's in their heart, nobody knows. Right? So I think that's what you cannot change. But at least when for a group of Muslim kids, I always tell them, focus on just doing the work. Don't focus on, and that's why don't think about what you don't have. Think about what you can do, what you can control. You can read, you can be smarter, you can be better, you could be tactile, you can be all those things. Nobody controls that, you control it. And then Allah's will, whatever is going to happen is going to happen. And that's how you have to look at it. And so that would be my little bit of off-ramp advice when you're dealing with your interactions with people. Don't assume that you're going to, somebody's trying to get you. Because I'm sure it's there. I don't doubt it. But it's not as much as you think.
What else out there, y'all? Any other questions?
Yeah, I know it's hard. Oh, there's
Yara,
there's a raised hand here.
Yeah, Yara, you can go ahead, or if you want to type it in, whatever, up to you.
Assalamu alaikum, Dr. Siddiqui and everyone. How are you?
Welcome, Salam.
I hope this is okay. I'm not a resident or a fellow. I'm already 2 years into practice now, so this is more of an advanced question, but kind of piggybacking on what you've said before. So I'm in private practice, and unfortunately, I come from a very heavy trauma-based residency, and I haven't been able to apply that because of the whole orthopodiatry situation, and hopefully looking to relocate and have better opportunities. But what are some advice that you have for young practitioners on how to stay up to date with everything other than just reading articles, attending? I guess because to be honest, it's kind of hard to find the drive compared to when you're in residency.
Yeah, no,
Come
life
home and
is hard. Like, trust me, guys, life is hard. and I'm fully cognizant of that. So yeah, your practice becomes what your community is and what your practice is. And that being said, you're right. You were in a trauma-based situation. Now you're in private practice, and then you're dealing with the local politics. I would tell you that you don't give up. If you really enjoy the other stuff, don't give it up. For example, when I first started, I think 80% of my practice was a diabetic foot.
Okay.
80%.
Wow.
And which is what is going to be for most podiatrists. It has to be, right? It's the lowest common denominator in what we treat and what nobody else wants to deal with. So, but I made sure I was the best at that I could be. Now, in my mind's eye, I was like, I'm still going to do the ankle replacement. I'm still going to do the bunion. I'm still going to do this. So I never gave it up in here. And so when those opportunities came, I made sure they were great. And then I built a reputation around it. And but my reputation was built out of the diabetic foot, of being a good practitioner of the diabetic foot. And then that's how it grows. I mean, for someone who's 2 years out, you're not going to be what you're going to be for at least 7 years. You don't know what that's going to be. It takes a long time. And it sounds ridiculous, but it's true. But so you have to have a mental commitment. So if you enjoy certain things, don't give it up. And I have done, and again, and eventually, like there was a guy in our group, he would not even send me anything besides a toenail. And now he sends me majority of things. But I've been in practice now, 2012, what is this, 13 years, in the same group with the same guy. But you know what it was? He realized I like golf. We talked about golf.
Yeah.
So, and then the trauma guys would send me infected diabetic ankle fractures. Took care of the ankle. So I didn't try to become a bull in a china closet and tell everybody I'm this. This is what I am. Yeah. I just did the work, but in my mind I kept it like I'm going to do all this stuff. And I think so that's easier advice for me to give than sometimes maybe for others to receive. Hang on one second. Let me plug my computer in. It's dying. So it's easier to give that advice 13 years later, I think, than it was at that time to receive it. But I had a hand surgeon who was in my practice. I was like, hey, what the heck? He was seeing like 90 patients, and I was like, how is he doing this? So then I started copying what he was like, okay. He's like, Noman, somebody comes to me for the index finger, they better not ask me about the pinky finger. I was like, that's brilliant. So I'm like, all right, somebody comes talks to me about the right foot. I'm not going to sit there talking about the left foot. Right? So, and, I think you have to start being deliberate about what you do, why you do it, how many patients you see, like you have to bite off more than you can chew and then chew it. My residency director, Guido Laporta, used to say that. And I really took all those things to heart. I never complained. I just did the work. And I'm telling you, if you have that, I'm being naive in that sense, but I do think that positive creation of that does help. So if you're like, hey, I want to be the ankle fracture queen of your community, I'm sure it will happen. But it's hard. It's hard. There's no question. So how do you keep up? To your part, how do you keep up? You're right. Reading is one thing, but at this point in your career, what you have, and is you have a lot more perhaps time available to take courses, industry-sponsored courses. I'll go to all of them. Break them out throughout the year, go to them, practice, but don't practice the way I see a majority of people practicing, especially the young practitioners, because what happens is they start thinking they know everything, and that's the dangerous part. And like I'll see them. Somebody like me will be there, somebody who's out, just used 2 years, they'll talk to me for a minute, they'll flex on me about how many cases they do, and then I see them in the lab, they'll do maybe minimum of that procedure and they'll bounce. And they've gone to the beach, or they've gone to dinner, or and that whole cadaver, you just leave it alone.
Hmm.
So I go into that cadaver and I'll sit there dissecting the heck out of it. That's what I did. Because I've had the benefit of teaching all these cadavers. I've just been dissecting the heck out of them to make myself better. But that's what I see. And then when I see the surgeon, and there are a few of them I've seen it repetitively at multiple courses, some of them are just there till the last minute. And I'm like, okay, this person is like using their time wisely. And, they're not just going to get a free trip from Synthes or Stryker or whoever the things may be. Or when I see them at ACFS, register for the ACFS, don't go to any of the lectures. Don't try to come talk to the panel. I'm always like, hey, especially for the Muslim kids, like Dr. Ahmed's point, is like if I had a Muslim guy who was speaking at the stage, I'd make sure I'd be like, all right, dude, you got to tell me. Because I did that with the other guys, the Dr. Hires of the world, the Jordan Grossmans of the world, the Lowell Wiles of the world, all these very famous podiatrists. I was just like, all right, I'm every meeting, boom, I'm there. I'm like asking them questions. I'm in their brain, because then the repetition of seeing that person over and over again, now they're like, okay, this person is a colleague and our interactions are completely different. So I think being very deliberate about how you approach the field is really important.
Thank you. Yeah, that's great advice. One thing that maybe, the residents, I was kind of a bigger change for me going as a resident, fellow, or practitioner is the lack of the diversity that you see. Maybe it's different for you because you're hospital based, but private practice, you're not seeing all those cases that you probably see as a resident. So also the confidence of, I used to do this and see this as a resident so often versus now it only comes, once or twice a month or every 3 months. So, doing those cases, like you said, I think the courses is a great idea to try and keep your hands busy.
Yeah, keep your hands busy, and that's it. Even if you have somebody who's a partner or a local person that you can scrub in with, and just be in and around it. When I was starting, I didn't have cases. I would go watch my joint partners or my orthopedic partners. I'd go into the case with them and just watch them operate on what they were doing, and because I just wanted to see what was, like their thought process. And you're right. But you're right. If it was sporadic for me in the beginning, sometimes I would do a lat stab and then I wouldn't do a lat stab again for like 6 months. So I know what you mean. And I would be doing, but in the interim, I'd be doing like all this diabetic foot. So especially on these amputation cases, I took it very seriously. I was like, all right, let me look at the tissue planes. I would dissect the heck out of it. I'd make sure that would be perfect. I would try different sutures. I would, like to see what the wound issues would be. Especially on these amps, I would be like, all right, they're falling into cave of Eris all the time. All right, let me try to see if I preemptively repair that in my staged operations. Let me do a lat stab at the same time to see if I can help that. Oh, let me reroute a tendon. So the diabetic foot became the maintaining my practice ground of doing procedures, and those have only helped me. So I'm not saying that you should do something that's not indicated. Obviously, I'm never going to advocate for that. But there's a lot of things that you can do to keep your hands moving and see the anatomy and the technique. So and I did do that. I used XFix as an offloading device. I'd used XFix for a fusion device in these diabetic feet all the time. So it kept so the diabetic foot has been good to me in that sense. And then my first patient I ever did an MIS bunion was a well-controlled diabetic. 7.1 was his A1C. I still see him. He was my first total ankle replacement too. So, and the reason he came to me was because he had thickened fungal toenails.
Right.
So I'm just saying that it's there. It's a lot harder. There's no question, but it can be done.
Appreciate it. Thank you so much.
Absolutely.
Jazakallah khair. I think that was very insightful. I know it's been an hour. We should probably cap it.
Yep.
May I ask one question before we
Sure.
Okay, I'm sorry. I'll try to make it brief. I know you had mentioned about the D1 schools and the sports medicine and the high schools that you've been able to cater to in the last few years. I've also followed some of your stuff where I've seen you go abroad on humanitarian slash educational things in Pakistan and in the region. Have you explored like sports medicine in the Middle East in countries like Qatar, or do you have any connections or like idea on podiatry there and how it's being practiced?
Yeah, see, podiatry is practiced completely different in the rest of the world. And nowhere is it practiced the way it's practiced here. And I think in England they have some version of that, but outside of that, really no. And DPM in the United Arab Emirates, and I think even Qatar for that matter. I think Qatar is more diabetic foot based from my discussions with there. So no, I think replicating what we have here, unless you have some good connections, I can't see it. You know, there are people, there are DPMs in like Saudi and all these areas that are doing it, but they're not leading, they're not orthopedic based, because they, you know, there's still a divide. But no, the mission trips, you know, I've been lucky because I've met, you know, there's a foot and ankle orthopedic surgeon named Mark Myerson. He's a very, very well-known foot and ankle orthopedic surgeon, and he and I became friends a few years back, and he got me involved in it because he would go to Pakistan, and he has an organization called Steps to Walk, so I'm faculty with those guys. And yeah, but I'll tell you this, you know, after doing these, when the guys abroad, they're very good. So if you ever get a chance to go work with an international orthopedic surgeon, it's very good because they have just so much volume, and so they can really help you with your skill set, and then you can help them with the focused foot and ankle stuff because they just do so much trauma abroad. But yeah, so yeah, no, I don't think in the Middle East. I know a few pediatric guys in Qatar and stuff like that, but in general, I don't know. It's mostly diabetic foot, I think, for DPMs.
Thank you very much. Thank you, doctor, for your time.
Sure. All right, guys. Well, again, I appreciate the invite. I appreciate your patience and time, and I'm sorry if I didn't answer your questions. You can always message me personally if you'd like.
All right. Jazakallah khair for your time again, and hopefully we can do something again in the future.
All right. Sounds good. Assalamu alaikum.
Thank you, Doctor. Assalamu alaikum.
Thank you guys for hosting this and everything. Assalamu alaikum.